It's really a pleasure to be here and to meet with you for this 8th annual Pre-Medical and Pre-Public Health Conference. Darrell Kirsch, who's the president of the Association of American Medical Colleges, spoke here last year, and he referred to this as the best pre-med event in the galaxy. I call it the rock star of pre-med events. It is really something special. Just think about it. 8 years ago, 40 students, pre-med students, attended this conference. 8 years later, if you include those who are looking online, it's over 7,000 individuals. A real tribute to you all and to the organizers of the conference. So it's a real privilege to be before you today, and it's an honor to be included among a very distinguished list of presenters. What I'd like to do this morning is to talk about two things. First of all, the status of healthcare in the United States, referring to some of the points that Dr. Pomeroy brought up. And then second, to focus on what we are doing at the University of California to address some of the ills that face healthcare in the United States. Now, on March 23rd of this year, a very significant historic event occurred when President Obama signed the Patient Protection and Affordable Care Act, the most significant piece of healthcare legislation since Medicare and Medicaid were enacted in the mid-1960s. Now, it's interesting that there are a lot of similarities between the bills that were signed in the mid-1960s and the one that was signed on March 23rd. First of all, they arose because it was realized that there were problems with health care in the United States. In the mid-1960s, it was realized that there was a significant portion of individuals in the United States, somewhere near 30%, who couldn't get the health care they needed and deserved simply and solely because they lacked health insurance. And those were individuals who were too poor to afford health insurance and individuals over the age of 65. So a single piece of legislation established health insurance for those two, the poor Medicaid and the elderly Medicare. And the health insurance came both from the federal government and the local government. Again, in response to an understanding that there was a terrible inequity in the healthcare delivery system in the United States. Another similarity is the signing of that legislation created great angst in the country, both in the 1960s and now. Now, I remember I was in training at Johns Hopkins just after the Medicare and Medicaid was passed, and my colleagues were talking about the ruinous effect it would have on the healthcare system. How would it take the delivery of healthcare out of the hands of healthcare professionals and put it in the hands of local and federal governments? Well, nothing could be further from the truth. Although there were some unintended consequences of what was done in the mid-1960s, overall it was a tremendous benefit to the United States and did allow a significant portion of Americans who couldn't access health care previously to get the health care they needed and deserved. Now, in a similar vein, it's realized that there are still problems with healthcare delivery, a healthcare system in the United States, and that was one of the reasons this legislation was signed and passed in March. And there are three areas in which healthcare in the United States really suffers. First of all, if you compare the United States to 30 other developed countries, in terms of the cost of healthcare per capita, per individual, we are the highest in the world, roughly twice as high as the next highest country, $10,000 per capita per year, compared to roughly $5,000 in other countries like Switzerland. Now, that would be okay if, in fact, we got what we paid for, but I would submit we don't get what we paid for. If you look at health status, the quality of health care, using parameters like longevity, how long people live, neonatal mortality, the death rate among babies just after they're born, obesity rates, heart disease, whatever parameter you want, we rank usually no higher than the middle and often at the end in terms of health status. So we pay a lot, but the quality of health care for the population of the United States isn't equally high. In addition, we have roughly 57 million Americans who can't access health care because they lack health insurance, and others who don't access health care because they can't afford to pay for it. So compared to other countries, we rank last in access to health care. We're the only developed nation in the world who hasn't found a way to ensure that all of the individuals in the country have access to health care. So we pay a lot, but we're not getting what we pay for in terms of quality and the ability of people to access the health care that they need. And if you simply look at on a graph, the top line, the red line, is the spending per capita going back to 1980 compared to 5 other countries, Germany, Canada, France, Australia, United Kingdom. You can see that the United States ranks highest. In 2004 is roughly $7,000. As I said, now in 2010 it's $10,000. And so the rate of increase is higher than any other country. So we are paying a lot for health care, and we're not getting what we paid for. And that was a major driving force behind the legislation that was signed in March. Now, what are some of the things that need to be done to get health care in the United States back on track? Well, they're numerous, and you'll hear about a lot of more about it as the conference moves on, and Dr. Pomeroy mentioned some of it. But let me go through some of the things that I think need to be done. First of all, we need to transition from a situation in which do it right rules what we do to do the right thing. When I was in train and I had to do a procedure, I was taught, make sure you do that procedure right, not whether or not that procedure was warranted or whether or not that procedure really added benefit to the health of the individual who was receiving that procedure. We have to change that paradigm to an outcomes-based and evidence-based approach. Not did we do it right, but did we do the right thing? Was what we did necessary for the health of that patient? Was the cost of what we did worth the benefit it provided to that patient or to that population of patients? And this is this outcome-based, evidence-based approach. Does the evidence really support what we do, whether or not we do it right? So moving from a do it right to the right, do the right thing is in fact occurring and will continue to occur. We need to move from a provider-centered to a patient-centered model of healthcare. The healthcare delivery system in the United States was developed primarily for the health professionals that are providing that care, not for the patient that's receiving that care. And we have to change that paradigm. And that paradigm is slowly shifting to a patient-centered model of healthcare. The healthcare workforce needs to look like the population it serves, and it doesn't. And I would submit if we don't have a healthcare workforce that looks like the population we serve, we can't do the right education, research, and clinical service to advance the health of that population. The overall statistics in the United States is roughly, for physicians, 10% of physicians are underrepresented minorities. Across the United States, first-year medical school classes is roughly 13% are underrepresented minorities, compared to 25% of the population being underrepresented minorities. In Texas and California, the differences are even greater. At the University of California overall, for the entering medical school class coming in next year, it's 23% of the students are underrepresented minorities, but we have a population in the state that's 45% underrepresented minorities. So again, if we don't have a healthcare workforce that looks like the population we're serving, we're not going to be able to do the best in terms of addressing the health needs of that population. We have to understand that healthcare is a team sport. It's not simply one health professional, a doctor or a nurse or a public health worker providing healthcare. But to address the health needs of individuals and populations, we need groups and teams of health professionals, doctors, nurses, public health individuals, pharmacists, dentists, community health workers, social workers, behavioral scientists, et cetera. And we need to understand that this is not simply a doctor-centric or a nurse-centric model, but it has to be a team of health professionals addressing the health needs of individuals and populations. And finally, we really have to focus on what causes death and disability. Dr. Pomeroy mentioned a lot of work and time is spent on the healthcare delivery system in the United States, and that is, while that contributes somewhat to the dysfunction of health in the United States, it is not the major contributor. If we simply ask, what are the causes of disability and death in the United States? Behavioral determinants account for about 40% of that. Genetic predisposition, 30%. Social determinants, status in the population, education, economic status, etc., roughly 15%. The healthcare delivery system, 10%, and environmental exposure, 5%. Now, if you add all this up, we actually can control somewhere near 70% of the things that cause death and disease. If you look at behavioral determinants, social determinants, and environmental exposure, and the health delivery system, things that we can control. Let's say we can't control the genetic makeup of an individual, but these others we can control, and in doing so, we can modify the health. In terms of behavioral determinants, if you look at smoking, roughly 750,000 premature preventable deaths still occur in this nation each year because of smoking. Obesity and associated heart disease, stroke, kidney disease, etc. Substance abuse and alcohol all contribute to diseases, and they are things that we can control. Social determinants, housing, education, etc. are things we can control. Environmental exposure, things we can control. But we are focusing so much effort on the healthcare delivery system. What this slide says is if we totally fix the healthcare delivery system in the United States, we would only make a small impact on the health status of the population. So here is a great opportunity for us to really understand what causes disease and death and make a significant difference in health status by moving beyond simply how healthcare is delivered. So the new paradigm will look something like this, and the good news is that you can be part of shaping this paradigm. This paradigm is nowhere near being implemented across the nation. There's a lot of discussion about it, feeling that this is the right way to go, but you, the future generation of healthcare professionals, are in a position to actually make this work. This is a patient-centered home. It's a virtual home. It's not a single place, but it's a place where information is kept and a place where the patient can go to have their needs met. There is a team of health professionals working in this patient-centered home: nurses, doctors, pharmacists, public health individuals, dentists, community workers, behavioral scientists. And hospitals and clinics are not the home anymore. They're not the place that the patient should call home. They're simply places where treatment and certain things can be done. But beyond the hospital and clinics, there are homes, there are schools, there are churches, there are transportation departments, et cetera, that play a critically important role in the health of the patient that is in the center of this patient-centered home. So this is the paradigm that we're moving to in this country, and it's one that you can play an important role in shaping. Now let me move to the University of California, and what are we doing to help move this paradigm forward? Well, Dr. Pomeroy referred to UC Health. This is the term we use to include all our health professional schools and hospitals, and we have 16 health professional schools. Schools of nursing, schools of dentistry, schools of pharmacy, schools of medicine, schools of veterinary medicine, schools of public health, and there are 16 of them. We have 10 hospitals, and they're on 7 campuses: San Diego, Irvine, UCLA, Riverside, San Francisco, and Davis. All our schools and hospitals are state and national leaders in the provision of healthcare, health-related research, and education, irrespective of what metric you want to use, whether they be achievement on standardized tests, U.S. News and World Report rankings, research monies, etc. Our schools are extremely prestigious, and hospitals are extremely prestigious in terms of what they do as individuals. What we're working now on is to get these 16 schools and 10 hospitals to work together in an integrated, coordinated way, so the total of what they create and what they can do far exceeds the sum of the individual contributions. And I think we've made some pretty remarkable strides in that direction. Now, just to recap some of the things that UC Health is doing in the areas of workforce access, cost, quality, and safety. In terms of workforce, we're looking at this from a quantitative and a qualitative standpoint. We understand the need to have more health professionals in California and across the nation. We had a pretty remarkable event here last night where UC Davis celebrated the inaugural class in their new school of nursing. And we were able to open that school last night. It was a pretty special event. We have another nursing program at our campus in Irvine that we would like to have that moved to a school. We have a medical program at Riverside, which is a 2-year program, which we want to create into a 4-year medical school. University of California at Merced would like to develop a medical school, and next year, a branch campus of UC Davis will begin there with 6 students. In terms of qualitative aspects, we really do get this issue of healthcare delivery and health being a team sport. At campus at Davis, San Francisco especially, this concept of interdisciplinary training, where medical students and nursing students and dentistry students and pharmacy students work together, where we have individuals, faculty from a school of nursing lecture to or give instruction to medical students, et cetera, so that health professionals understand what they can do as part of the healthcare delivery team during the educational process instead of learning that once they graduate. And they have to learn what a physician assistant does, what a nurse practitioner does, what a dentist does, what value a pharmacist brings to the health of individuals or populations of patients. So we do get this concept of a team approach to healthcare delivery, and we insinuate that concept into the educational process. Access is critically important. We have roughly 23% of the residents of California who don't have health insurance, and because of that can't get access to the health care that they need, and working to address that, and I'll talk a little bit about what we do using telemedicine. And we are very concerned about cost, quality, and safety. Now, this is something academic health centers, and an academic health center is at least one health professional school, usually a school of medicine, in conjunction with a teaching hospital, and we have at least 5 academic health centers. Academic health centers have not always been attuned to these issues as they should have been in the past. And we're making strides to correct that and really looking at issues of cost, quality, and safety, and I'll show you an example of this in a minute. One of the programs that we're particularly proud of is called programs in medical education, called PRIME. These are individuals who are selected to attend medical school, not only based on their achievement in the classroom or on standardized exams, but by their commitment to address the health needs of medically underserved populations. That commitment is critically important in their being accepted into this program. We have 5 of these programs associated with our 5 medical schools. We're actually starting a 6th, which is going to be a branch program of Davis next year. In the aggregate, they have 250 students. In the past, or last year, 55 of those students were underrepresented minorities. Actually, for the entering class coming now, it's 58%, compared to the average of 23% in a regular school of medicine, compared to a national average of around 13%. So these are a very special group of students who really want to go back into the communities that they came from to address the health needs of that community. And do it not through just delivering health care, but through prevention and wellness. And we hope we can expand this population. We use telemedicine to address this issue of access. Now, over in the corner, if you can see it, there's an individual with a young child and a screen. Telemedicine uses telecommunication to deliver health care. It allows individuals to communicate at great distances using telecommunication. The distance can be 5 miles or it can be 5,000 miles. When I was in Texas, we used telemedicine, and we took care of individuals. I remember a goat herder who had Rift Valley fever, a virally induced illness, and we were taking care of him 7,000 miles with doctors in Galveston, Texas, and the patient was over in Africa. And you can do with certain attachments, you can listen to the heart, look in the eyes, ears, nose, and mouth, and you can do everything you can do face-to-face a patient without touching the patient using this telecommunication. The University of California was asked to develop a statewide network called the California Telehealth Network, and it includes 863 sites throughout the state of California. that we are in the process of putting together and connecting via telemedicine. So rural areas can connect with clinics, clinics connect with academic medical centers, physicians can connect with nurses, and we can go to where patients work and where they live to deliver health care, as opposed to expecting them to come to the clinics or to the hospitals. And this has and will have a tremendous impact on access to health care. Understanding the importance of quality and innovation, and to take advantage of the innovative things that are going on at our UC campuses in terms of cost, quality, and access to health care, we have developed a system-wide center to provide financial support for projects that go on at individual campuses that then can be rolled out to the entire University of California system and hopefully beyond the University of California system and beyond California. And these projects relate to access to health care, the development of healthcare workforce initiatives that address the team approach, et cetera. And one example of what we've been able to do in quality is indicated in this slide. The red line indicates the incidence of infections associated with intravenous lines, lines that are put into veins, usually, to deliver medicines, et cetera. A complication of that is an infection associated with that procedure. We realized that this was something that we needed to fix. When we started in 2008, the incident was roughly in excess of 3 infections per 1,000 line days. That's just a way of providing a uniform measurement. That was actually higher than the national benchmark. We then challenged our 5 medical centers to develop best practices to lower that infection rate and learn from one another. So UCSF, for example, learned what San Diego was doing in terms of hand washing. Davis learned what was going on at Irvine in terms of what could be done to prevent these infections. And these weren't just doctor-centered. Nurses participated in this. Custodial workers participate in this because the development of infection relates not to just what a physician does, but it relates to what a nurse does and to what others do. And by learning from best practices, we were able to move from a rate of greater than 3 in 2008 to a rate of approximately 1.4 in the first 2 quarters of 2010. That is much better than the national benchmark, but it shows you what we can do when we put our minds to it and take the great intellectual capacity that we bring to our research enterprise to our clinical enterprise and say, we want to have a significant impact on quality. We're now doing this in several other ways in the same context of learning from one another, and I'm sure that we will continue to make great strides in terms of quality. So those are just some of the things that we at the University of California are doing as part of our responsibility as a public trust to address the health needs of society, to make health care more affordable, more accessible, and of higher quality. Now let me end with 2 quotations. The first is by an individual who's very dear to me, William Osler, the first chairman of the Department of Medicine at Johns Hopkins. I actually was honored to sit in the William Osler distinguished chair when I was chairman of medicine at Johns Hopkins. But William Osler changed the way medical education occurred in the United States by doing 3 things. First of all, he emphasized a scientific basis for educating physicians. Second of all, he moved that education from the laboratory into the clinic. And thirdly, he emphasized the importance of humanism and compassion in the education and practice of medicine. And what he said pertains not to just physicians, but to all healthcare professionals, and is so true. The practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. And this relates to not only taking the science that you learn as a health professional, but exercising the compassion and wisdom that allows you to best utilize that scientific knowledge. Now, fast forward to 100 years later, to the remarks of Kofi Annan, who was the 7th Secretary General of the World Health Organization, who went beyond the interaction between an individual health professional and an individual patient, when he said, "It is my aspiration that health will finally be seen not as a blessing to be wished for, but as a human right to be fought for." And as you proceed in your decisions to enter the healthcare profession, and I hope you will, I hope you will take this as a very important charge, and you will advocate for health and health care in this nation to be a right available to all, irrespective of their race, of their ethnicity, of their gender, of their financial, or their immigration status. Thank you for your interest in health care, and thank you for your attention this morning.